Good evening, esteemed members of PSK. Thank you for joining us today. If you can hear me, just type on the chat. Let us know which PSK branch you're joining us from. Good evening, Dr. Wata. Karibu. Good evening, Dr. Christabel, Dr. Omar, Dr. Peter, Dr. Ali. Karibuni sana. Thank you for joining. Thank you. Thank you for joining, Dr. Jackson from Nairobi branch, Dr. Beatrice from Eldoret. Karibuni sana. So meanwhile, as we wait for our colleagues to join in, kindly go to the PPB portal and search for this event, Management of Early Pregnancy Complications using Combipack, and use the keyword Combipack to find this event. As we wait for our colleagues, kindly go to the PPB portal and subscribe to this event. This is the keyword Combipack. So also, as you subscribe for this event, kindly ensure that you also subscribe to all our past events that we've had before. Subscribe to all the events that we've had before as PSK. And for this specific event, kindly search for the keyword Combipack, and you'll be able to find this event. The title is Management of Early Pregnancy Complications using Combipack. Thank you all for joining. For those who've just joined us, good evening. We are currently subscribing to the event on the PPB portal. Search for the keyword Combipack and you'll be able to find this event on the PPB portal. So kindly subscribe. All right, thank you for those who are subscribing. So we'll just get started. First, I'd like to welcome you to today's webinar, which is on management of early pregnancy complications using Combipack. And our sponsor for today is VIA. And during this session, you'll also be able to hear from them. Our speaker for today is Dr. John Nyamu. I believe you all know him. We've had him before in our previous session. He's the National Coordinator at Reproductive and Maternal Health Consortium, Kenya. Once again, to remind you, kindly subscribe on the PPB portal. The keyword is Combipack for this event. Just a few ground rules just before we get started. Is to remind you that you'll be muted during the entire course of this session. So kindly, if you have any questions, use the Q&A tab and not the chat, because most of the questions that you ask disappear on the chat. So kindly use the Q&A tab when you're asking a question so that we'll be able to track it well. And for all PSK members, kindly again, subscribe on the PPB portal. And to remind you again, this session is being recorded and it will be made available on the PSK YouTube page. So for today's session, we'll be having Dr. John Nyamu, who will be presenting on the topic of the day. And then thereafter, we'll have a presentation from Peter Maura from VIA, and also some remarks from Charles Mwangi, who is also part of VIA team. So at this point, I'd like to welcome our speaker today, Dr. Nyamu. I don't know if you're able to hear me.
Yes, I can hear you.
All right, karibu daktari.
Thank you. And can I be able to share the screen?
Yes, please. Just
Okay. I hope now you're able to see the screen. Just trying to see what I can. Are you able to see my screen now?
yes, we can see.
Let's see if I can just slide show.
Yeah, I think it's okay now. You can go ahead, Daktari.
Okay, yeah. Good evening, everyone. My name is Dr. John Nyamu. As you have been told, I work for Reproductive and Maternal Health Consortium as a coordinator. And today I'm pleased to join the PSK fraternity to share some of the guidelines the Ministry of Health has developed recently. One of them is on Combipack, which is a combination of mifepristone and misoprostol, mostly recommended for the management of early pregnancy complications. Yeah, and this is my presentation outline. We will define common Combipack drugs, legal status of Combipack in Kenya, mife and miso combination, clinical characteristics, oral drug information. Then there's brands of Combipack in Kenya, and I will talk about the Medabon, which is one of the Combipacks, which is being marketed by VIA Health. And we also will mention about contraception. So Combipack is a packaging of 2 or more medicines or tablets using blisters, that is aluminum foil for durability. These drugs have independent and complementary mechanism of action. Mifepristone and misoprostol combination complement each other in the evacuation of the uterus to manage early pregnancy complications. So the complications we are talking about in early pregnancy are blighted ovum, missed abortion, intrauterine fetal death, and any other medical condition of an emergency nature which occurs during the first trimester or then during the first 10 weeks of pregnancy. So Combipack is not new to us, and of course, as pharmacists, you are better placed to know that a Combipack the Combipacks are everywhere, and this Combipack of mifepristone and misoprostol is not unique. The only uniqueness with it is that it is used for medical uterine evacuation. Otherwise, there are several other Combipacks. Maybe the first one is for bacterial vaginosis, fluconazole, azithromycin, secnidazole, tinidazole, meprazole, clarithromycin can treat vaginal infections, and sulfenacin and tamsulosin treats BPH, that is the condition affecting the prostate gland. And then for mifepristone and misoprostol, the combination is for 200 milligrams mifepristone and misoprostol is 800 micrograms. And considering that misoprostol is 200 micrograms each, then this combination is 1 tablet of mifepristone and 4 tablets of misoprostol. So the Combipacks are not swallowed or at the same time. They are taken at intervals. For example, the mifepristone might be taken on the first day, and the misoprostol can be taken on the second day. They are not taken at the same time. So what is the legal status of mifepristone and misoprostol Combipack in Kenya? As I mentioned in my opening statement, Combipack has been registered here in Kenya, and also, of course, by the Pharmacy and Poisons Board, and it was registered. The first Combipack was registered around 2013. It is also on the Kenya Essential Medicines list of 2019, which is being reviewed now. And it is one of the medicines recommended for the management of postpartum hemorrhage by the DRMH. This is the Division of Reproductive and Maternal Health. And it also appears in the Maternal and Neonatal Health Register as other drugs. That is, when all the other drugs have been put in the register, Combipack is included as other drugs, and it is instrumental in the management of IUFD. That means intrauterine fetal death. And as you know, intrauterine fetal death is a pregnancy which has died inside the uterus, mostly within the second trimester, and it must be removed to avoid complications such as excessive bleeding at the time of expulsion by the body. So the MOH has developed the national guideline on mifepristone and misoprostol, that's the Combipack, in May 2023. That is, I think we are going back. So that's the legal status, and that's how the booklet looks like. The Combipack guideline, national guideline on mifepristone and misoprostol combination, or Combipack, and therefore pharmacists should be able to know that there is such a guideline which is there from the Ministry of Health. And the guideline has two parts. The first part is clinical characteristics, that is the drug information. And the second part is the clinical application of mife and miso. How is it used clinically? And the first one is what are the characteristics of this drug? We go very quickly to the clinical characteristics or drug information. This is the information which actually even the client is going to ask the clinician, like pharmaceutical form. Is it a tablet? Is it a capsule? Yeah, and a combination blister package of 1 tablet, and I said earlier, and 4 tablets of misoprostol. Mechanism of action: the mifepristone is antiprogesterone, while a misoprostol is a prostaglandin. What that means is that mifepristone, if it's an antiprogesterone, it will lead to changes in the endometrial lining, softening and dilatation of the cervix, and increased uterine sensitivity to prostaglandins, and therefore it might lead to detachment of the early pregnancy. Misoprostol, being a prostaglandin analog, softens the cervix and increases uterine contractility, and it causes expansion by contracting the uterus, hence achieving the medical uterine evacuation. So that's why we said that both drugs are complementary. One detaches the embryo, the fertilized egg or the fetus, and then the second one causes contractions and expansion. So mode of administration, this one is very important because in drugs, recommended mode of administration, the mifepristone is oral, that you swallow with water, and misoprostol, the recommendation is sublingual. You put all of them under the tongue for 30 minutes and then swallow the remainder after 30 minutes if everything has not dissolved. Misoprostol can also be taken orally, buccally, or vaginally. What about the expected side effects? This product causes GIT side effects because it causes contractions of the smooth muscles of the gastrointestinal tract. So you expect the client to complain of nausea, vomiting, and diarrhea. But the expected side effects are cramping, vaginal bleeding, and those ones, of course, they are the expected ones. But the common side effects are the ones I've just mentioned: nausea, vomiting, diarrhea, headache, maybe shivering, chills, and dizziness. But if the client asks you what are the side effects, then you tell them that of course, the expected side effects or the expected effect of the drug is bleeding and pain, so that they don't say that now they are feeling a lot of pain and they are bleeding too much. So you just tell them the bleeding will be there, pain will be there, but the side effects, the common side effects, which are transient and go away within 2 to 3 hours, are nausea, vomiting, and diarrhea. Those are the GIT side effects. What are the precautions? One of them, of course, is a bleeding disorder. If someone is having any bleeding disorder, then you have to be very careful giving the medicine and for the client to go home with the medicine. You may need to have the client treated in the hospital. Another condition where you need a precaution is anemia. For IUCD, you remove the coil before the Combipack is used. And renal failure is another case where the prison can cause dehydration or low BP. So in shock patients, you have to be very careful. Breastfeeding, you breastfeed the baby before giving the medicine, because the medicine passes into the breast milk. For scanned uterus, there is no contraindication, but it's a precaution. You have to observe the client. And of course, uncontrolled asthma is another precaution. So these are precautions. The precautions mean that the client can be treated, but under observation, or you can admit the client in the hospital and manage the client. The reason why I'm talking about the hospital is because the Combipack is normally given as an outpatient medicine. So what are the contraindications? Allergy to mifepristone, severe anemia, and active genital tract infection. Those are the contraindications. If you find the client has allergy to mifepristone or misoprostol, or they are severely anemic, because if they bleed, the anemia can be worse, or active genital infection, whereby it is also not recommended, because it can make the infection worse by the fact that the client is bleeding, cervix is open, the client can get a more severe form of infection, and therefore the infection can be disseminated into the blood system. So the other issue about this drug information is about storage and shelf life. It's important to know that the mifepristone and misoprostol usually carry only a 2-year shelf life. And the expiry date you mentioned, it should be the last day of that month, not the beginning of the month, because the shelf life might be written, or expiry date might be written April, but you tell the client the last day of the month is the expiry date, not the first day. So the storage, of course, you should store away from heat. It should be stored at room temperature. And therefore room temperature is around 21 degrees centigrade, so the maximum you can go is at 25. So if the temperatures are very high, it's not going to store the mif and miso combination. However, the blister package containing aluminum foil preserves its potency. So what are the drug interactions? Avoid antacids that contain magnesium, because they might make the diarrhea worse. Use of alcohol and other substance of abuse worsens dizziness. So I think it's not good to give the client if they are taking too much alcohol. The metabolism of mifepristone can be increased when they combined with modafinil, which is a psychotropic drug or psychostimulant. It's used for psychotic depression. The risk of severity of QTC prolongation can also be increased when mifepristone is used in combination with arsenic trioxide, which is a cytotoxic drug. The risk of severity of QTC also prolongation, those are the heart waves, also increase when mifepristone is combined with the quinine or artemether. These are antimalarial drugs. So when the client is being treated, you ask the client if they are taking any other medicines, or if they have taken alcohol, antacids, alcohol, antipsychotic drugs, cytotoxic drugs, and malaria drugs. Those ones you should try and ask the client, because they might cause complications. So those are the characteristics, the clinical characteristics. Now we look at the clinical application of mifepristone combination. How is it used in these conditions like blighted ovum, missed abortion, early abnormal pregnancy not compatible with life, or any other medical indication of an emergency nature? So the first thing that one must do is client assessment for Combipack use. That is, the client should not come to the pharmacy and then say they want misoprostol, and then or mifepristone and misoprostol, and then you give without knowing exactly what is the history of that client. Because the client could be having a pregnancy of 13 weeks, the pregnancy could be normal, and therefore, and the indications as indicated above, it is supposed to be used for emergency indications only. So the client might come and, of course, during the assessment, you might ask about the history, the medical history, reproductive history, if they have been referred by people to the facility. Examination, if you are a clinician, you can ask, do general systemic and abdominal and pelvic exam, or you ask them if they have been examined or if they have been done an imaging. So it is important for you to ask for evidence of clinical assessment. So for the instructions on the use of Combipack, before administration of medication, inform the client about the medical evacuation drugs and their mechanism of action. This is now, you just discuss or counsel them and talk to them about the clinical characteristics. Mechanism of action, dosage, common side effects, mode of administration. You also discuss about the pain management, contraception, and the contraceptive options or contraception options. And the follow-up is always 14 days after the medication has been given, because the medicine might work immediately within 24 hours or even 2 or 3, 5 days, but we recommend that the client should come back for checkup, or you should contact the client after 2 weeks. That's the recommended follow-up period. So the embryonic pregnancy or blighted ovum, the dosage is mifepristone 200 milligrams, which is 1 tablet on the first day, and then the second day you give 4 tablets of misoprostol sublingual. Missed abortion, that's same, also below 13 weeks. One tablet of mifepristone on the first day, then the second day 4 tablets of misoprostol. Medical emergencies in the first trimester, as long as it's less than 10 weeks or 10 weeks and less, then you give mifepristone 200 milligrams, and after 24 hours give misoprostol 800 micrograms or 4 tablets sublingual. So the dosage actually for Combipack is the same within the first 12 weeks. So post-medication management, upon administration of drugs to the patient, the management is that you should give the client analgesics. The analgesics which are recommended for medical uterine evacuation are NSAIDs. Those are ibuprofen, diclofenac, and mefenamic acid. And paracetamol is not recommended by the WHO, but these NSAIDs are the drugs which are recommended for 3 days. Antibiotics are not routinely administered unless you suspect the client might be having an infection, in which case you give a treatment dose of antibiotics. Sexual intercourse may resume after the bleeding stops. That's after about a week. Vaginal bleeding may last up to 2 weeks. That's why we said that the follow-up should be after 2 weeks. Information, counseling, and service on contraception or preconception as appropriate, and treat anemia if present. So this is what you do after the post-medication management, or rather the post-medication management. Immediately after giving the medication, You can discuss about contraception options. You can discuss about painkillers, analgesics, antibiotics, and when to come back. So if anybody knows their brand group, it is recommended that you give anti-D, which is around 300 micrograms IM within 72 hours. But if they don't know their brand group, you don't bother, because sensitization is not likely within the first 3 months of pregnancy, the first trimester. So you provide the emotional support also, and also provide linkage or referral to other health service providers as required, or health services as required. That means that, for example, if the client develops any complications, you can tell them to go to the nearest health care facility. The major signs during treatment, of course, is intense abdominal pain, especially on one side. Then you can suspect an ectopic pregnancy. Heavy vaginal bleeding, where they are changing 2 pads or more per hour. And if there's no bleeding after 24 hours, is a major sign, because the client might be having an ectopic pregnancy, or maybe the process has failed. So it is important to check with the client, or you tell the client if in 24 hours they have not started bleeding, then they should come back, or they should go to the nearest healthcare facility. Another major sign is persistent fever of 38 degrees centigrade, because that is more than 38 degrees centigrade. That means that if the fever is around 36 to 37.5, you may not be bothered much, but you can observe the client. But if the fever persists and is more than 38 degrees centigrade, is a major sign of sepsis. The full smelling vaginal discharge is also a sign of infection. So during the medication, you may have, the client may want to tell you that, you ask, are you feeling any pain? Are you having, how heavy is the bleeding? Have you started bleeding within 24 hours? Is there any fever and forced smelling vaginal discharge? Success rate is 99%. In fact, one of the reasons why I wanted to show you about this Medabon, there was a study which was done on Medabon, and it indicated the success rate of the Combipack is 99.2%. So it is 99% effective. If you give misoprostol only, which is actually given at 4 tablets 3 hourly for 3 doses, that's about 12 tablets, then the success rate should be around 95%. But if you do the combination, then the success rate goes to 99, almost 100%, that's 99.2%. So for excessive bleeding, then of course the diagnosis is use of 2 pants in 1 hour, and the management, of course, should be surgical approach. In case the client is having retained products of conception, they go to hospital, they are evacuated, and then they are transfused if necessary. For infection, of course, this is an admission case. The fever, of course, is over 38 degrees centigrade. Also the same, you just you observe you check the client, you see if they have retained product of conception, then they go for evacuation, and then you are given parenteral antibiotics. Retained products of conception, if the cervix is closed, you give misoprostol to open up the cervix, you take them for evacuation also, then give antibiotics. Ongoing pregnancy, there's an issue of an ongoing pregnancy, because in case someone comes and tells you that the pregnancy is not coming out, IUFD or whatever, then you just take them for MVA also. That is evacuation through surgery, not medical. If it has failed, and then you use medical means. You use MVA means that's a surgical. So the follow-up after 10 to 14 days, again, client should be assessed for recovery, and make sure that the uterus is well contracted, there is no bleeding, no signs and symptoms of complications. You can do targeted physical examination that includes pelvic examination, assess the woman's fertility goals, and also discuss about contraception and link it to other services. So after the 14 days, you just come in to check whether the client has recovered from the uterine evacuation. So some of the brands which are in Kenya in the market are Medabon, which is marketed by Via Health, manufactured by Sun Pharma in India. Marie Priest is also marketed by a local organization, Maristops, but manufactured by Acme Laboratories in India. Then we have MA Care, which is marketed by DKT and manufactured by Nari in India. And the Safety Kit, which is marketed by Lawrence Healthcare and manufactured by Janani in India. So you can see most of all the drugs, actually, all these Combipacks are manufactured in India, but they are registered in Kenya, and one can be able to access them or to purchase them either from the pharmacies or the marketers directly. You can just have this presentation and find out who are the marketers and where you can get these Combipacks. So for Medabon, this is how it looks like. Of course, it's a Combipack of mifepristone and misoprostol, 200 milligrams mife and 800 micrograms miso. And you can see the blister pack, the one I was talking about. They are covered in a blister pack, and then they are put in a Combipack, in another packet. But the most important one is this blister pack, which has covered the tablets, and which means that the tablets are going to be safe and from moisture, and therefore they will last long. This is a picture of how a Combipack should look like, whether Medabon or any other Combipack. There is mifepristone on one side and misoprostol, 4 tablets of misoprostol on the other side. So the dosage should be the first tablet of mifepristone on the first day, 200 milligrams. And then the second day, you take all the 4 tablets of misoprostol sublingual for about 30 minutes, and you can dissolve in case they have not dissolved all of it. So mifepristone and misoprostol for uterine evacuation are included in the WHO list of essential medicines, and also in Kenya essential medicines list. Mifepristone used alone does not cause an abortion, but works in combination with other prostaglandin like misoprostol. So what this means is that in case you want to terminate IUFD, or if you are terminating missed abortion or content of uterine evacuation, for example, there is retained products, you cannot use only mifepristone. You have to combine it with the misoprostol. So it is always used in combination with the misoprostol for uterine evacuation. The mechanism of action is that it detaches, mifepristone detaches the IUFD or missed abortion or blighted ovum or whatever the pregnancy, and therefore and misoprostol causes the contractions. Then that's how the product is expelled. And then again, this is the mechanism of action: prostaglandin blockade, and this pseudo-necrosis, cervical opening, and detachment and expulsion. So the 2 drugs work synergistically. One causes detachment and the other one causes expulsion. That's the registration certificate of Combipack. I said they have been registered since 2013. So this is the acceptability study of Medabon in 2015, and just want to go to the side effects, whereby mifepristone and misoprostol both gave GIT side effects. That's why I was mentioning that if you are discussing with the client, then you make sure that you tell the client they are going to have GIT side effects. Otherwise, and shivering and fever was also reported in 16 to 30% of the clients. Headache and dizziness, 8 to 30%, and the expected side effects were abdominal pain and vaginal bleeding. So after giving the mife and miso combination, you must tell the client they are going to have fever, they are going to have GIT side effects, so that when they go home, they don't go and complain that they are having malaria or something else. And this is the study. Also, we will share these PowerPoints: nausea, vomiting, diarrhea, headaches, dizziness. These are the various side effects that were reported with the mifepristone, and these ones are reported with misoprostol. So you can see the side effects are actually similar, but for misoprostol there are more than the mifepristone. Yes, and then the success rate was 99.2%. The post-abortion contraception report study showed that number of women cancelled for post-abortion contraception was 92.7%, and the ones who took up the contraception was 89%. So it is important for you to advise the client to take contraceptives immediately after the uterine evacuation. So for the contraception, you can either, if you are doing medical, medical evacuation, then you can give medicines immediately. Medical uterine evacuation, we give hormonal IUD, hormonal contraception. Those are the pills, injections, implants. Those are the hormonals. And then for the IUCD, it has to be interval. You have to do it after the medical evacuation. But if you are giving, if you are doing surgical evacuation, then you can give hormonal contraception immediately, or you can even give IUCD immediately. You can just refer the client for insertion of IUCD after the evacuation. So basically, the reason why we are discussing this is because for medical uterine evacuation, the client must be cancelled about contraception, and they can take the medicines, or either medicines, hormonal medicines, like combined oral contraceptive pills. They can take the DMPAC, the Synapres. They can have self-care of any other hormonal or barrier methods that they need to have after the evacuation has succeeded. So the implication of this study was that the Medabon was highly effective in evacuation of the uterus, which is 99.2%. It is very important for us to discuss about this hormonal contraception, and also the various other methods of contraception which the client may want to have. One of them is combined oral contraceptive, the injectable, progesterone only, implants, barriers, patch, IUCD, natural methods, permanent, outer course, emergency contraception. All these ones the client may want to have, to get after they have been cancelled. The standard days method is another method which the client can be told about if they don't want to take the hormonal contraception or IUCD. And this one, it states that if the cycle is between 26 and 32 days long, then the unsafe days are the 8 and the 19. And one can use cycle beads for the standard days method. So the characteristics of contraceptive methods also you should discuss about the classification, mechanism of action, side effects, effectiveness, contraindication, drug interactions, and technique of use. In case you want to venture into this area of contraception, then you should have also all these characteristics in your mind. The mechanism, how they work, side effects, effectiveness, contraindications, drug interactions, and technique of use or mode of administration. These are the same medical eligibility. These are criteria which is used to find out exactly which method is fit for the client. Then those are you see this insertion procedure. This one is for medical team or medical people, but for pharmacists you can discuss about emergency contraception, which is P2, or mifepristone has been found to be effective in the use as an emergency contraception, and I think it's under registration right now. So management of bleeding after using progesterone-based contraceptives, the main treatment is you give estrogen-based products like oral contraceptive pills or Noriganon, which is a 1-month injectable. And recently we have found that mifepristone can also be used to treat this bleeding caused by progesterone-based contraceptives. So you give 10 milligrams of mifepristone daily, maybe for about a month, or you can give 50 milligrams of mifepristone weekly, and then it causes amenorrhea and also reduced bleeding. Mirena is also another coin impregnated with the progesterone, which can be used if the client is having painful periods or if they're having excessive bleeding, especially due to fibroids. There are newer contraceptives like Cyanopress is a new 3-month contraceptive, which can also be used as a self-care, but the client has to be trained how to inject themselves first before they start using. We also have Implanon NXT, which can be discovered by an X-ray in case it is lost or if it is misplaced. So basically, this just discuss about the Combipack, and there's also the issue of contraception, because if the the uterus has been evacuated, they may want to go for contraceptives, and the pharmacist should be able to have a knowledge of the types of contraceptives which are in the market, and especially the new ones like Cyanopress and Implanon. Thank you very much.
All right, thank you so much, Dr. John, for that insightful presentation. So just before we move into the questions, I'd like to invite Peter Moura from VIA, who's just going to do a presentation on some of their products.
My presentation.
All right. Right, you can just share your presentation, Peter.
Hi, good evening. So first, I would like to invite Charles to make some opening remarks.
Thank you, Peter. Good evening, everyone. I want to thank everyone for your participation in today's webinar. And mine is very brief, just to mention who VIA is, because it's a very new entity in the Kenyan space. We are hardly a year old. We were registered in March of 2021 and started operations this year. But VIA is a fully registered commercial company that is wholly owned by Population Services International. The reason for VIA is basically that once PSI being an NGO, once you have a donor a project coming to an end, and there is need to continue with the project or the service or a product, then VIA is the arm that is earmarked to ensure that the continuity and availability of the product or the service that has been there. For instance, I could give an example. We've just been going through the HIV self-test kits, which was a program that was being run by PSI through different implementing arms or different implementing companies or organizations. And you may see very soon that we may have HIV self-test kits now commercialized such that they are no longer donor supported. So that's the purpose of VIA. And of course, with me, I have Peter, a colleague, and I also have Ted Ogada with me, who are in the field, and the three of us will be visiting you to give you more insight on what products and what services VIA is offering. Thank you very much.
Okay, thank you, Charles. So I just take a few minutes to highlight some of the products that we have from Via Health. And among them is the Combipack that we have been talking about. So Via Health Enterprises is pleased to introduce Medabon. And Medabon is a prescription-only combination therapy. So in the chat, someone asking whether you are talking about Combipack as an OTC. No, we are talking about Medabon as a prescription-only combination therapy. So just to reiterate on the direction of usage for Medabon. So we saw that we have one is a Pristone and 4 misoprostol. So the Pristone 200 milligrams per second orally, and then after 24 to 48 hours, we do the 800 micrograms of misoprostol, either vaginally or sublingually. So these are 4 tabs of 200 micrograms each. So as I said, so when you're using, why would women prefer to use a Combipack Medabon as opposed to use any other method? So we are talking about women prefer a Combipack because one, it's non-surgical. So the woman can self-manage and take some of the medication at home. She can take the misoprostol maybe in the facility, and then she can take the misoprostol at home and do it sublingually. It's affordable and it's effective. So we are talking about the 99% effective when you're managing in different indications. So the other thing is that it's more private and discreet, and she feels more in control and gives her the peace of mind. So one of the things that we are really insisting on is the quality of the medication that we're giving. So as highlighted by Dr. Memo, is that Medabon is manufactured in a WHO approved facility. And when it comes to the packaging, is that as you can see, we have a double aluminum packaging. So inside here we have a desiccant, just to ensure that the misoprostol is in a very dry environment. So we are ensuring that the quality of this product that we are giving is it's maintained throughout the supply chain. So as we say, the combination therapy of mifepristone and misoprostol is 95 to 98% effective. The other product that we have introduced is Avatiso. Avatiso is our misoprostol, and we are still insisting on one thing: the quality that you can count on. So this from the feedback we got from the pharmacist, from the doctor. So the challenges we have sometimes the challenges we have in misoprostol in this country is reliability. You want a product that is quality. So you're having a product that is tested twice in 3 ways. So it's tested, one is manufactured in a WHO approved facility, and each tablet is packaged in a cold form aluminum foil. So the two tests, one is once by the manufacturer and once by independent third party in a WHO approved laboratory. So we are looking at three analytical techniques in this. We are looking at the physical properties. So this is to validate the stability of the drug molecule and to ensure that the tablet and the packaging will not degrade over time. So when you say it's a 2 years shelf life, we want to assure you that by the end of the 2 years, the quality of this product is maintained. The other thing we are looking at is the chemical composition, where you like to evaluate the chemical structure and ensure that the concentration of the specific component, and the bioavailability of the product. The other thing we look at is the microbial contamination, ensuring that there is no impurities or foreign microbes. So Avatiso, say, is a pack. The difference is a 4-pack. So we have 200 milligrams, 4 tabs of it, making the 800. So we are talking about the management of incomplete miscarriage or abortion. So incomplete abortion can result from either spontaneous loss or an induced termination. So it occurs when the products of conception are not completely expelled, and this can lead to serious complications. So 90% of the patients with incomplete abortion reported being satisfied with the use of misoprostol. So as I said, the use of misoprostol as opposed to surgical, it feels more natural. The client can avoid surgery. She feels more in control. And it's described because she can take in the comfort of her home. And it's less expensive than surgery, and inpatient care is not needed. So these dose cards, these have been borrowed from the FIGO guidelines. So we are looking at the dosage in the first trimester, in the second trimester, and that trimester. So we are looking at the dosage for missed abortion, for complete abortion, for cervical preparation for surgical abortion, and also for pregnancy termination. So this guideline, this dose card, we are planning to share these with you guys so that we have the dosage at the fingertips. Then the other products we have is Meuri. Meuri is our third generation COC. So it contains desogestrel and estradiol. So when you're looking about the third generation, here we just want to highlight the different generation of the progestin that we have and the activity on the different receptors. So the most common one, I think, for the COC is the second generation, the combination of the levonorgestrel and estradiol. And what we are introducing is the third generation, which is the desogestrel and estradiol. So you can see the activities, especially less activity on the androgenic receptors, meaning that the drug is better tolerated. So Meuri, as we highlight, one of the advantages of Meuri as a combined oral contraceptive, we talked about the tolerability. So we have low rate of bleeding irregularities. We have lesser weight gain. We have no amenorrhea. So we have frequencies of nausea, headaches, which are some of the side effects that the client we talk about. And we have a lesser chances of acne and hirsutism. So Meuri as a third generation combined oral contraceptive is effective in the long-term management of PCOS. So there is no side effect on the lipid metabolism. And also when you're managing PCOS and you want to manage the menstrual disorders. So in the studies, we experience that there's a decrease in menstrual blood loss about from 60 prior to the combined oral contraceptive to that 6, so about 50% decrease in the menstrual blood loss. So it also improves the pre-existing acne in 80% of the clients, and also help in reducing hirsutism in around 50% of the clients with pre-existing hirsutism. So this is how Meuri is packaged. A package contains 21 hormonal pills and 7 inert tablets. So we take the 21 and the 7 just to as reminder pills. So the third product that we have is Pronta. Pronta is 1 tablet emergency pill. So instead of the 0.752 times, Pronta contains 1.5 levonorgestrel. So it's a progestin-only emergency contraceptive. And one of the things that we are trying to look at is the compliance for the patient, for the client. So the client will be able, instead of this, she might forget the second tab. So by just taking 1 tab, it's as effective with a better patient compliance. So levonorgestrel have a prolonged one life, and Pronta is registered as a single dose. It removes the risk of forgetting or delaying the second dosage. So Pronta is the same, comes from a long lineage of PSI being an NGO. So you have PSI have been in existence for more than 50 years, from 1970. So it comes from that long lineage. So as I say, still the usage should be taken 72 hours within 72 hours of unprotected sex or in the failure of regular contraceptive method. Its benefits, its effective method, it works actually if used within 72 hours. It's easily available and can be used by women of all ages. So just a summary, those are the products that we have: Medabon, Meuri, Pronta, and Avatizo. I've shared the contact of Teddy Ogada, my colleague, and myself. In case of anything, you can always reach out to us. Thank you. And I think I'll hand it back to to the moderator for the Q&A.
All right. Thank you so much, Peter and Charles, for taking us through that presentation. So we'll just move right into the Q&A session. And for our members, you can just take a screenshot of the contacts that are being displayed there. If you have any questions, you can always just reach out to them. So the first question on the Q&A is on it's by Dr. Arthur, who says, I have seen many doctors prescribe the fluconazole, azithromycin, secnidazole trial kit, Combipack to be taken all at once. In such a case, how do you advise the patient? So maybe Dr. Nyamu, you can advise on that.
I think that most likely this question is coming because I had mentioned that Combipack of mifepristone and misoprostol should be taken separately for it to be effective. For it to be effective, the two drugs do not interact with each other. They don't cancel each other, but you can still take them together. The only problem is that you need to give mifepristone time to work, because the way it works is that it detaches the pregnancy from the uterine wall, and then it gives time for the misoprostol to work. If you give them at the same time, then it means that it's like the misoprostol is working on a pregnancy which is not well detached from the uterine wall. So there's no contraindication of using the Combipacks. It's only that for this one, we recommended that, or rather the WHO recommended that instead of taking them together, you can give it time. By the way, initially, it was the time which was given was 3 days, then it came to 2 days, then now it's saying 1 day. So as we go, maybe probably they might say that you should give them on the same day. And also what we know is that you can still give them on the same day, but you give mifepristone maybe 1 or 2 or 3 hours before, then you can give misoprostol after that. If you are giving them at the same time, then you may need to repeat the dosage of misoprostol later, because sometimes there might be a slow mode of action. So for effective function for the mife-miso combination, it's better to give them time, maybe 1 day time or 24 hours time, for it to work perfectly. But for the other combination, as I said, there are so many Combipacks. The recommendation is that they can be given together, because their mechanism of action is different. And especially now you are looking at antibiotic and antifungal. I think the work they are doing is different, so you can give them together. But this one, we are saying that they are synergistic. They are doing something, the same thing. So it's better to give one after the other one.
All right, thank you. Thank you so much for that feedback. There's also a question from Dr. Paul, who's asking, can mifepristone 600 mg be used as a family planning pill?
Well, the recommendation of mifepristone as family planning, I think I mentioned, is only 10 milligrams, because 600 milligrams is too much. Because even for abortion or uterine evacuation, the recommended dose is 200 milligrams. So if you are giving, you want to give it as family planning, then you should give it, you should give as an emergency 10 milligrams start, or you can give 10 milligrams every day for the whole month, or you can give 10 milligrams from the 8th to the 19th. Those are the options which have been standard for mifepristone. But if you are giving now 50 milligrams, 100 milligrams, 200 milligrams, you are talking about uterine evacuation. And this one, what you are giving is family planning, so that the client does not conceive. So, and dosage of 600 micrograms is so high because, as I said, mifepristone has got side effects of nausea, vomiting, and diarrhea. So by the time you reach even 200 milligrams, there's already nausea and vomiting. So if you go to 400, the client might have so much vomiting and so much diarrhea and fever. And by the time you go to 600 micrograms, the client will be dying of all these side effects. So it's important to go by what is recommended by WHO. For uterine evacuation, the maximum is 200 milligrams, but for family planning, you use 10 milligrams.
All right, thank you. I hope, Dr. Paul, your question has been answered. Then we have another one from Dr. Joshua who asks, when does the menstrual period come back after using the Combipack?
Yeah, for Combipack, as we all know, uterine evacuation, once the uterine evacuation has been done within the first 12 weeks or within the first trimester, it is like menstrual regulation. In fact, there are some countries where uterine evacuation within the first trimester is called menstrual regulation. The reason why they call it this way is because the periods come after 1 month. It's like a period. After the evacuation of the uterus within the first trimester, you expect a period after 1 month. That's why we talk about menstrual regulation. And therefore, if you give, for example, the medical evacuation now, then you should expect the next period to start after 1 month. If there's any delay, delay can only be around 2 weeks, not more than that. But most of the clients just follow their cycle.
All right, thank you for that. Then the other one is on what causes the Combipack to fail sometime?
Yeah, for the study that we did, we found that the Combipack is 99.2% effective, and in most cases, it was the people who are bleeding after 14 days because the failure is actually if the evacuation has not occurred within 2 weeks or within 14 days. We realized that there were only retained POCs. The bulk of the POCs had come out, it was just retained POCs, which means that it's like the Combipack is 100%, but since the client is bleeding and the criteria of a failure is bleeding after 2 weeks, that's why we took up the issue of 99.2%. But in most cases, the Combipack will not fail. In case you find that the Combipack has failed, that is within 24 hours, if somebody has not started bleeding or if the uterus has not started expelling the POCs, then you should think of other causes. You should reevaluate the client and find out whether the client could be having ectopic pregnancy. If the client is having uterine fibroids, because with uterine fibroids, the uterus does not contract well, so the product may not come out. So you may need to do an ultrasound also to find out whether there is some abnormality of the uterus or the cervix. And this is a case where clients need to come back and then be referred. If the client has been given medication after phone consultation, then you should tell the client that within 24 hours, if you feel that the method has failed or nothing has happened, then they should go to the nearest healthcare facility for examination and for pelvic ultrasound to rule out these conditions I've just mentioned. Thank you.
All right, thank you so much. I think we'll just take 2 last questions. So there's a question on, is there a cause of concern when the client uses the medication, but only bleed on the first day, then it stops?
The first day, if the client bleeds the first day and then it stops, it depends on the amount of bleeding, because what we know is that the evacuation can occur even within the first day, even within hours. So it depends on the gestation period. That's why it is important to find out exactly how many weeks the client is. If the client is 4 weeks or up to 6 weeks there, I would expect if the bleeding is minimal, then most likely that gestational sac may have come out or something like that. So it's important when you're doing a clinical assessment, you should also make sure that the gestation is well known. If the gestation is 8 weeks, 9 weeks, 10 weeks, and they bleed only once, one day, then you know that there's a problem. But if the client was only 4 weeks, just missed a period, and she bled only one day, then there's no problem with that. What you can do is just you confirm by sending the client for an ultrasound to confirm whether all the POCs have come out. Thank you.
All right, thank you so much. And then I think the last one is just on, someone was asking on where they can get the guidelines. So maybe if you can give
for the guidelines, I think, you know, they were developed in May, and I'm not sure whether they have been, the minister has printed, but what I can recommend is you can contact Via Health. I'm sure they have an electronic copy, and they can share with you. Because you can use the electronic copy for the time being.
All right, thank you so much, Dr. Nyamu.
Okay, welcome.
Yeah,
and
so
thank you for everyone for listening and for your contribution.
Yeah, so I think maybe we'll just move into the parting shot. Maybe you could just say something, then I'll allow Charles and Peter and Dr. Mungoma to also say something just before we close.
Yeah, maybe what I can say is that I'm very happy to work with the PSK and also Via Health and the PSI because I've got an interest in reproductive health, and mostly I engage myself with supporting the Ministry of Health to develop these policy standards and guidelines. And I'm happy if these guidelines are going to the community or to the counties for use by the service providers. By the service providers, I mean even the pharmacists. Now that we have the idea of self-care coming on board, you may realize that the Combipack will be very useful for women to be able to manage their treatment independently. That is the drug of the future, and therefore it will be important for Via Health and other partners or other marketers of Combipack to bring them to our shelves. The pharmacists can be dispensing them, and then the women will be able to access these products from the chemists. Thank you very much for listening.
All right, thank you so much, Dr. Nyamu. Peter, maybe you could also give your parting shots.
I just want to thank everyone who created their time this evening to log into a webinar. I can see some people are sharing the email for the sharing of the slides. See how much of the slides we can share, and then we continue working together. I've shared our contact. You can always reach out to us, and we can help out in any way we can. Thank you.
All right, thank you so much. For our attendees, we're going to see how we're going to share the slides when we'll be sending out the certificate of attendance for this webinar. So Charles, you can take it over.
Thank you, Doc. Once again, I want to thank everybody, and I want to take this occasion to specifically thank Dr. Nyamu for your kind and attendance to this and good presentation. And also I want to thank the PSK fraternity for allowing us this opportunity to speak to you all. And I want to also mention to you, and I'm sure Dr. Mungoma, who is here, we've been working together on a journey that we are also going to be partnering on other issues that he'll mention to you. And I would probably want to just mention to you, probably he has already communicated, we are also going to be doing something called community vaccination, a pilot that we want to do with those pharmacists that have community pharmacists, and see whether we can be able to enable a working environment where, as a pharmacist, you're able to give certain vaccinations at your outlet. But I'm sure that the organization PSK will be talking to you about it, but we are hoping to do this from early 2024, as early as January. So we, once again, thank you so much for giving us an opportunity to work with you. Thank you.
Right. Thank you so much, Charles. At this point, I'd like to welcome Dr. Michael Mungoma, who's the chairperson for PSK Education Committee. Dr. Mungoma.
Yes, good evening, everyone, and thank you so much, Hezron, for managing until this point. You're doing a good job. I want to say we are so grateful for having Dr. Nyamu again speak to us. This is the second time. We're really gaining a lot of knowledge around reproductive health commodities management as pharmacists, and it's important to realize that there are more and more health products and technologies that are coming our way, and we need to have good knowledge and develop the skills of managing not only the products, but also the clients and patients that would be using them. I also want to thank Via Health for their support. We've come a long way to this, and we're also looking forward to what Charles just mentioned there about the other program that we are fine-tuning. And definitely as we continue upskilling pharmacists and carefully looking at all the opportunities around provision of primary health care, even at community pharmacies, it is important for all the members of PSK just to remain attentive and remain keen on what PSK is doing and what we're planning to do even into the other year, 2024. So I believe that that even the young pharmacists, I think those are the ones that I really want to encourage, because this is important. You need to start coming and occupying some of these spaces. And even for the older pharmacists, let's continue talking and mentoring. And we hope that this platform remains useful for everyone. For those that are joining us for the first time, this is part of our continuous professional development platform and program that PSK enjoys. You gain CPDs that Hezron is going to, maybe has already mentioned how we get that. And we want to try and ensure that everybody remains up to date as regards to pharmacy practice. So thank you, everyone, and back to you, Hezron.
Right. Thank you. Thank you so much, Dr. Mungoma, for those remarks. So I think we are done with the closing remarks. I'd just like to once again thank Dr. Nyamu, Peter, Charles from VIA for supporting this, and also Dr. Mungoma and Dr. Anita Cheng, who's been supporting as well. So just before we end, I'd like to just take our members through a slide over here. Once again, to remind you that you need to subscribe on the PPB portal so that you can get your CPD points, and the keyword is Combipack. For members of Nyanza branch, PSK Nyanza branch, there's a symposium that is coming up on 2nd December. So kindly take note of that. It will be happening at Sarova Imperial Hotel in Kisumu. Another activity that is coming up, webinar, which is on antimicrobial use in community pharmacies. Kindly take note of that, which will be happening on 28th of November, starting at 7 p.m. Then there's also a National Sub-County Pharmacists Consortium that will be happening on 28th at 2 p.m. So kindly be on the lookout for communication on that. Then finally, there's a skills workshop that is coming up. It's a comprehensive pharmacy skills workshop that will be trained on different skills. The early bird will be ending on 24th. So kindly take note of that, 24th of November, and the late bird is 30th of November. This will be happening at USIU on Saturday, 2nd of December, from 7 a.m. to 7 p.m. So thank you so much. Those are just the announcements that we had on our end. So thank you so much for joining us, and kindly again, remember to subscribe on the PPB portal because this determines how fast you'll get your CPD points. For all the events that you've not subscribed to, kindly do so early so that you can get your CPD points. Thank you, and have a good evening.
Thank you.